we're lucky to be in this time. To me, it's almost revolutionary the way the new imaging has changed practice, at least for myself, and we can get some feedback later from some of the other physicians in the audience. But for me, it really has changed practice in a really large way, and so I think it really is an exciting time to be practicing in the prostate cancer treatment and diagnostic arena. So let's go quickly. So typically, pattern of failure, I think you can break it up into three main areas. You have local failure, which is in the after radical prostatectomy, is recurrence in the prostate bed. For radiation, obviously, it can be recurrence in the prostate itself, and that's after external beam radiation therapy, SBRT, brachytherapy, or any type of focal therapy, cryotherapy. The next area is really nodal recurrences, which is really fascinating. We'll be talking about that as I go over some of the PET information. But obviously, pelvic nodal disease is considered regional disease, not metastatic. Well, traditionally, para-aortic, paracaval nodal metastases have been considered to be metastatic disease. And of course, then you have the most common site of distant metastatic disease in prostate cancer, which is bone, and then followed by visceral organ metastases. So traditional imaging, as we know, when we either work up a patient initially or for rising PSA, is the bone scan. They also have sodium fluoride PET scans, which are supposedly a little bit more sensitive in picking up metastatic disease in the bone. Those have been the traditional ways of imaging bone. And then of course, there's the traditional CT scan looking at nodal metastases primarily, or changes in the prostate bed or in the prostate itself. And now we have the multiparametric MRI, which is also very good, but it's been used primarily in the detection of the de novo disease staging, newly diagnosed prostate cancer, et cetera. What about newer imaging? Well, this is where I think we're at. So we kind of started to get into this. One of the first agents that we started using our field was the Prostate 11 in Capramed pentatide single photon emission CT. There was some promise in it in terms of trying to detect recurrences after radical prostatectomy in the prostate bed. And we'll talk about why that's not so important. And then we have PET imaging, which is, I think, where it's all at, and that's where I'll spend most of my time. And you can kind of break up the PET imaging into two types of things. One are radiotracers, and I'll talk a little bit about some of those. And then what's coming down the pike is prostate-specific membrane antigen inhibitors and antibodies, again, all used to detect recurrent disease primarily. So this is a JAMA Oncology review published in 2017. And the table is mechanism and diagnostic efficacy of PET radioligands for prostate cancer imaging. And on the column on your left, you could see the radiotracer. So I'll just kind of go over it and some of the mechanisms of action. So C11 choline, which was originally only available at the Mayo Clinic, was one of the first and important ones to really show things that we had not seen in detecting microscopic recurrent disease. It's a cell membrane synthesis. Then F18 choline was also used as another radiotracer. Cell membrane synthesis was the mechanism of action. C11 acetate was lipid synthesis. And now F18, FACB, or better known, and this is part of the confusion, is the fluciclovine, which you've heard mentioned here. This is something we've had a lot of experience at Mount Sinai, part of one of their original protocols, looking at how this test changes the management of prostate cancer. That is amino acid transporters, its mechanisms. And then you can go down the line and see There's the sodium fluoride PET that I said, again, really to detect bone metastases. And what's coming down the pike, and people are very interested in, not necessarily commercially available at all places, there are some places in Europe that are doing, is the gallium PSMA, which is a PSMA analog. And then there's other PSMA inhibitor antibodies, and this is kind of where we're going and looking at which one is really going to be the best. So I'm going to kind of talk to you what I think currently is the best that we have, certainly commercially available. So this is a paper published in the Journal of Urology from a group in 2014, and basically what it's doing, it's, I'm just going to use fluciclovine because it's easier to say, positron, PET scan, comparing it to the Prostate scan, and looking at the PET CT for recurrent prostate cancer, and it was a prospective clinical trial. If you kind of look at this table, you can see you have the fluciclovine in the first column, and then you have the Prostate scan in the second with p-values. And what they're doing is just kind of comparing things. The first thing they're doing is looking at its ability to detect disease in the prostate bed. So in terms of true positives, they had 55 in the fluciclovine arm versus 41 in the Prostate scan. The number of true negatives were 12 and 17. Number of false positive, 18 versus 13. The percent sensitivity was 90% for the fluciclovine versus 67% for the Prostate scan, and the accuracy was 74% versus 64% for the Prostate. In terms of extraprostatic disease, they had 70 patients. The number of true positives were 22 for the fluciclovine and only 4 for the Prostate scan. The percent sensitivity was 55% for the fluciclovine versus only 10%. That was significantly different. The specificity for the test was 97% versus 87%. So, and the accuracy, importantly, was 73% for the fluciclovine versus 42%. So I think this trial really demonstrated that the fluciclovine was a superior agent for imaging recurrent disease than the more traditional Prostate scan. And this is kind of just showing some of the pictures, kind of comparing it. So what you have here is an 80-year-old patient who received external beam radiation therapy, cryo, and brachy for an increasing PSA to 1.6. He had a biopsy. It was positive. Then they used the Prostate scan in images A, B, and C, and then the fluciclovine test in images D, E, and F. So you can see that the area of uptake here is in the prostate itself, and you can see in the Prostate scan, you see the seeds in place. You don't really see anything in the nuclear medicine version or in the fused version. While we use the fluciclovine, you'll see that little dot in the column E indicating a local recurrence within the prostate, and you can see that kind of pink in the fused image of the nuclear medicine and the CT scan. Here's some more images, again, demonstrating this is a 65-year-old patient after external beam radiation therapy and cryotherapy, who then had an increasing PSA to 13.8. It's pretty high. He had biopsy-negative prostate bed, but he did have a lymph node. So if you look at A, B, and C, that's the Prostate scan. You can't really see very much, but if you focus, and this is kind of what, when you start to see these things, this is what you're going to do. These are very small lymph nodes that are being shown. Almost all of them are less than 1 centimeter. And what you will see is this little tiny dot. So if you look at E and you look at F, you will see that little tiny dot in the periaortic chain. And that's something that you prior to this, were unable to really image and see this. So let me turn to another paper. This was a multi-site experience looking at the safety detection rate and diagnostic performance of fluciclovine PET scanning for recurrent prostate cancer. And really here you're going to see some interesting images. So if you look at A, that's kind of an image in the prostate bed there. And now you see on image B, you have a presacral node. Again, these are nodes that you were not picking up, but you can see by the size of it, they're quite small, less than 1 centimeter. But they do light up like this, and I can tell you anecdotally the experience of what our approach has been, and I can stop and talk about it now, has been to try to aggressively treat these areas, and we've been doing this with different forms of radiation, usually in combination with hormones, but these things will actually disappear, and it's quite rewarding to do this. C, you can see that there's a lesion in the bone that lights up on the fluciclovine. And this is a 61-year-old male with a PSA rising to 0.4 after prostatectomy. And the fluciclovine test here detects a 8 millimeter mesorectal lymph node. You can see it with the arrow. It's quite clear when you get these. And so what you do is you look at the SUVs also. It's determined where, and usually typically what we're seeing is SUVs of 3 to 8. Sometimes you'll get really high SUVs. It's very easy to see these. And interestingly, these in plain CT imaging, despite the high SUV uptake, you would not be able to see this in CT, traditional CT imaging. And this is just a table showing the fluciclovine outcomes versus primary standard of truth. And you can just see the number of patients, the lesions, prostate bed, extraprostatic, and the subject matter, and then you're looking at the positive rate. For the lesion, for the prostate bed is about 58%. Extraprostatic is where you, again, really highlighting 81%. Doing that, the positive predictive value here is 62% for the lesion, 71% for the prostate bed, 92% for extraprostatic disease. So this really is an emerging test that's been quite successful in our practice. Here is another paper that's comparing the fluciclovine now to, as I said, one of the first tests in the United States was the C11 choline, which was available at the Mayo Clinic. So I don't know if any of you have sent patients there, but I know I did in the earlier years to get this test, and actually saw some very interesting findings. But this is an actual, in the Clinical Nuclear Medicine Journal, a comparison between the two. And the results were that on a patient-based analysis, the fluciclovine detection turned out to be significantly superior to the C11 choline tests, a significant p-value. And the result was also true on the lesion itself, on lymph nodes, bone lesions, and local relapse analysis. There was no significant difference in terms of target to background of positive lesions between the C11 choline and the fluciclovine. And when the patients were divided into the PSA groups, so you would imagine that the higher the PSA, the more likely you're going to get a positive test result. The fluciclovine had a superior detection rate in both the low, intermediate, and high PSA levels. So here's some of the imagings here. So the fluciclovine axial cut A, and then B. So the top images of the fluciclovine, the bottom images are the C choline. And here you're talking again, if you're looking at this very small para-aortic lymph node, and you can see in C that where the arrow is, that it is detecting this on the fluciclovine test. When you look at that same patient being imaged on the C11 choline, again, you can see this on the CT. It's a tiny node, which you would never call abnormal on a typical CT scan, but it doesn't really image very well. It's not picked up with high SUV on the PET imaging using the C11 choline. Here's another example of a patient now with an intact prostate, and again, the top images are the fluciclovine, and the bottom are the C11 choline, and it shows increased uptake in the prostate bed consistent with the local relapse. And again, you can see the arrows pointing to the lesions. So although the lesion does image slightly on picture E with the C11 choline, you can see there's a much greater uptake on the fluciclovine test. Here's some more images from the study. This is a fluciclovine axial cut showing increased uptake in the right sacroiliac area, consistent with a bone relapse. And again, the images on the top correspond to the fluciclovine, and the images on the bottom are corresponding to the C11 choline. So you can see that lesion, I think, in all the images here, A, B, E, and F. You can definitely see that, but you can see the uptake on A, how much greater that uptake is, and the nuclear medicine portion of that. And you can see that in C, much greater uptake in C than it is in G, which is the C11 choline. And this is just figure 6 from that particular paper, which shows the detection rate of the fluciclovine and C-choline in relation to different groups of PSA when the test was taken. So you can see in the PSA levels of less than 1, 1 to 2, 2 to 3, greater than 3, the higher the PSA, the greater the detection rate. But you can see in all of those groups, the fluciclovine is superior to the C-choline test. This is another kind of review article that's kind of reviewing new clinical indications, and this is focusing on the F18 and the C11, both choline tests and new tracers for the PET tomography and promising hybrid device for prostate cancer staging. And this is a review article, and it just kind of goes through some of the various references, the type of imaging that is using, and here they're using C11 choline, F18 choline, and at the bottom is again the FACB, or the fluciclovine test, and kind of looking at both sensitivity and specificity. Again, it's hard to read this, but you can see that in the bottom test you have very good sensitivity and specificity for the fluciclovine test, and for the comparative imaging, again you can see the differences there between the various isotopes. And again, this table just looks at the prostate-specific antigen cutoff points to detect lesions. And you can see, of course, now as the PSA is less than 1, you have a 19% likelihood of detecting lesions. When it goes from 1 to 2, it goes up to 46%, and certainly over 2. So if you were going to wait, and sometimes I do with my patients, I'm trying to wait to the point where I can get the most bang for my buck. So I have a patient, PSA is creeping up. You may want to watch that for a while. Again, it depends on the rate in which it's rising, because you know that if the patient is presenting to you with certainly after a radical and this PSA has gone from 0, 0.1, 0.2, 0.3, you can get this test, but your yield is going to be much lower. If you then get that test where the patient has a PSA of 2 after a radical, you're much more likely to detect disease. I think that's the point of this slide. So again, going back to this review article, looking at the various agents, has some good pictures in the article to kind of demonstrate. This again is the fluciclovine imaging demonstrating multiple local, regional, and distal nodal mets in a patient with prostate cancer. And here you can see a man in his 60s with newly diagnosed prostate cancer. On image A, he had Gleason 9, PSA of 12, and the fluciclovine combined with the PET imaging and the CT fusion shows intensity in the gland. You can see those images here. Here's just another example of someone with nodal metastases, and you can see this is someone who has obviously disease in the thorax. In image B, in image C, you have disease in the para-aortic regions that light up. So what's interesting, and we have submitted an abstract this year to Astro on this, which is how do you use this when you're giving radiation therapy? Because again, when are you using these tests? Primarily you're using them, most often, at least what we see, is in patients with radical and a rising PSA. So can you use this before you give radiation? Should you use it before radiation? Sometimes we're seeing it in some of our patients who have failed either brachytherapy with rising PSA or external beam. But this particular article focuses on how does it change what you do when you give salvage radiation therapy in a rising PSA. So let me just kind of talk you through the results of the study, because it is really interesting. So they basically had 44 patients, 2 of them dropped out. So they had 34 patients, 81%, of the 42 had positive results on the fluciclovine. So that's a pretty high number. 80% of the patients with a rising PSA had positive fluciclovine numbers. The original radiotherapy design, so in other words, if I had seen this patient before the advent, traditionally I did not, if the nodes were negative, did not treat the pelvic lymph node regions. So let's say my field would be the prostate bed. Well, how did the scan change this? So overall radiotherapy decision was changed in 40% of the patients. So that's a pretty high number. The mean PSA, original Gleason score, post-prostatectomy PET interval did not differ significantly between patients with and without radiotherapy decision changes. So about 5% of the 42 had a decision of radiotherapy withdrawn due to positive extrapelvic findings. So here's a situation where you're getting the test, you were going to treat the prostate bed, but now you have disease outside, maybe in the para-aortic or in the thorax, and in that 5% of those patients, they're not going to get their original plan for radiation. And then the radiation therapy field decision was changed in about a third of the patients of the 42. 73% of the 15 that had field changes went from prostate bed to prostate bed and pelvis. So that's typically, I think, the real utility of this test is that you may take a patient who you would traditionally just treat the prostate bed, and you get the scan, and the scan shows you some lymph nodes that light up in the pelvis, and you go from a prostate bed field to include the pelvic lymph nodes. And so 27 of the 15 had field change from prostate bed and pelvis to prostate only. So there was some situations where after the test, maybe your practice was to treat the nodes, but you get the test and it does not show any nodes, and you want to reduce the morbidity, so you just treat the prostate bed. And just a very complicated graph, though, kind of showing you the patients, starting out with 42 patients who had the fluciclovine PET CT scan. Then there's N26, radiotherapy of the prostate bed only. That was the initial plan. And then 16 patients who were going to get the prostate bed and the pelvis treated. And then it shows you all the fluciclovine results on the second line here. And you can see how the treatments, the final treatment changed. So this is a really great test, a great test to get for rising PSA after a radical, and it really can and does influence how you design your salvage radiation therapy treatment. And so finally, I want to add on some stuff, just kind of introduce it because I think it's coming down the pike. Most of this is only available in controlled trials, but the gallium PSMA, this is a prostate-specific membrane antigen, radiolabeled choline and prostate cancer is now being used. It shows you some of the results, shows you kind of a picture of a comparison between a patient who had an 18F choline PET scan with the radiotracer versus the gallium PSMA test. You can see much greater uptake with the gallium test. So I think this is something is coming down the pike. We're really in a very exciting era. If you have not used some of these tests, I would recommend strongly that you get involved. I think the fluciclovine is being marketed with the company Blue Earth. It's called the Axeman scan. I think that's probably most people in the audience could get this at some place, and I would, based on my own experience in the literature, I would recommend using it. Thank you.